All right. Welcome to the Natural Science Seminar. Today we are excited to have Jeff Evoy as our speaker. It's always great to have an alum come back. So I suspect Jeff might tell just a little bit about how he got into health information systems. When I think about the history of computing, we started out by creating tables. We needed a machine to do calculations, and then it found its way into business and banking, and then IT became significant in the manufacturing revolution and manufacturing in our country. But now IT is a significant part of healthcare. So I'm excited to hear what Jeff has to say, how healthcare is changing your visit to the doctor, your overall health insurance and health care. So give a good hand to Jeff Evoy.
Thanks, Professor Hayward. I'm not sure I can give you an easy path on how I got from where I started at Spring Arbor to healthcare. Because I went from Spring Arbor in physics and math to Utah and got my degree in geophysics. I did my thesis research in Yellowstone. So I'm not sure how that ended me up in healthcare, but somehow we ended up here. But it is good to be back. I will say that the education I got here has been incredible, and it's a good call for you to be in this environment and in this kind of a setting, because it really has been a great benefit to get a liberal arts and a Christian liberal arts education. Do you want to talk about healthcare? Not only because I'm working in it now, but it is by far the greatest transformation of any business in American history. It's happening so fast and it's so drastic, in many ways uncontrollable right now, what's going on in healthcare. So I just wanted to talk real quick about what's going on. Now, I guess the good news is we do have the best healthcare system in the world. I mean, that's kind of a given. America has the best healthcare system in the world, unless you look very closely at it. There's been a number of studies done, but one in particular, they compared the quality of healthcare in America to several other countries. And the point is, well, what do you measure? I mean, there are dozens of ways to measure quality of healthcare. Is it life expectancy? Is it are we curing cancer better than Canada? Is it infant mortality? I mean, there are dozens and dozens of ways to measure the quality of healthcare. And what this group determined was, we really don't know whether we're doing a better job or not. We do know that in some ways we're doing better. America is ahead in cancer treatment. We are way behind in infant mortality and in life expectancy. If you want to live longer, don't live here. You know, Switzerland, there's some other countries that'll give you a lot better chance of living longer. Bottom line is, we say we have the best health care in the world, but there really isn't any evidence to support that. We're not, I mean, we got some of the greatest technology and some of the coolest instruments, but are they being used to the best in terms of providing health care? And it's not necessarily the case. But at least we've got the safest health care, right? Except for things that go on that aren't so safe, like medical errors. Institute of Medicine did a study in 1999, and they called it "To Err is Human." And what they found out was, I think I just shut my machine off. Okay. What they found out was between 44,000 and 98,000 people die every year from medical errors in hospitals, preventable errors of all kinds, surgical errors, medication errors. It is the 8th leading cause of death in America, is our healthcare system. They're killing us more than breast cancer, AIDS, or motor vehicle accidents. And there's a law firm that did this. If you want their twist on it, they say it's the leading cause of death in America is our healthcare system. So come let us sue somebody for you. So you can put the numbers another way. But medication errors alone, wrong dosage, wrong drug in the hospital, kills over 7,000 people a year. And I say kill because it does kill them. It's not just a matter of making them sicker. There's over 1 million medication errors in the hospitals a year. 7,000 of them kill the person. And our good friend Newt Gingrich, if you ever read articles about medical errors, you'll see the jumbo jet analogy. And he quoted this years ago, and anytime anybody writes a paper on medication errors or medical errors, they have to quote the jetliner analogy. So the bottom line is, this is the equivalent of a jet airliner crashing every week in America. And so his point is, how long would the U.S. airline industry survive if we were crashing one jet airliner a week with no survivors? Maybe the second week. And yet we live with this in the healthcare setting all the time, and yet we're killing that many people. Other errors. More than 10 years later, you'd think it would have gotten better. Between 99 and now, it's actually a little bit worse. In some cases, they're saying in Medicare studies, as many as 1/3 of hospital admissions end up with some kind of an error. So, don't mean to scare you, but if you get admitted to the hospital, the odds are 1 in 3 that's they're going to goof up with you somehow. You hope it's just a minor one, like, you know, short sheeting your bed or something, rather than giving you the wrong dose. And some of these are absolutely tragic. There's a drug called heparin. It's a blood thinner. There's an adult dose and there's an infant dose. And if you want to go Google heparin infant deaths, you'll find story after story after story of cases where they put the wrong dosage in, where the tech put the wrong inventory in. They put the adult dose in the neonatal unit. And in one case, an entire staff of nurses administered adult heparin to their entire nursery and watched while all the kids died screaming. So we didn't just lose the infants, we lost all those nurses. None of them survived it in terms of being able to function as a nurse again. Simple mistake, human error, killed a bunch of little babies and threw a lot of qualified professionals out of healthcare. They just couldn't deal with it. Surgical errors, my goodness. I mean, how many times you hear about sponges and stuff being left inside patients and wrong. There was a guy that went to the hospital and he literally said, this one. He had it in marker on his arm, you know, operate on this one. Because he knew a lot of times, whoops, he might pull out the wrong, you know, cut off the wrong arm, whatever. Anesthesia mistakes, needless surgeries, hospital-acquired infections. This is a little close to home. If any of you profs remember my older brother Larry, who before his death was the Northern Michigan Conference Superintendent for the Free Methodist Church. He had congestive heart failure. He did not die of CHF. When they put his pacemaker in, he acquired a deadly infection and he was dead in a month. From a hospital-acquired infection because they didn't have proper procedures for infection control. He should still be here. He's one of those stats. My pilot friends and I can't believe doctors perform such incredibly complex procedures without a checklist. You know who Sully Sullenberger is? He's the pilot who landed the plane on the Hudson River with no loss of life. And I heard him speak at HIMSS a couple of years ago. He said, we just can't believe you people do this. I mean, we don't even turn a plane on without a checklist, and you guys are going to do a 6-hour procedure from memory. He says, we just can't believe that you'll do that. But we do. Well, at least the good news is we have the most cost-effective health care. Well, maybe. Except for the fact that we spend almost 17% of our gross national product on health care, compared to the world average, which is down there, you know, about under 9. 1/6 of our economy is being spent on health care. Dollars, over $7,200 a year per person in America being spent on health care, compared to the world average, which is under $3,000. So we're way over twice as expensive as anybody else to get our level of health care. So what's wrong with the system? Why is it not changing? Why is it not getting better? Are we doing anything about it? Well, one of the fundamental problems for the last 100 years has been how doctors get paid. It's called fee for service. And what it means is they get paid regardless of what happens to you. You come in, they see you for a visit, they do this, they do that, they draw your blood. They either bill you or the insurance company, and they get the same amount of money whether you get better or not. In fact, if you come back next week with the same problem, they're going to get more money. The more services they perform, the more money they make. Got any math majors, physics majors? Who knows? You all familiar with boundary conditions? You just push your model to the limit, either set x equal to 0 or infinity. Well, bottom line is, what were to happen if every one of a doctor's patients were healthy? They'd go broke because you wouldn't come in to see them. What's wrong with this system? What's wrong with the payment model, with the business model? Now, they've started enacting some caveats to start cutting into this. For example, Medicare says, if you make a surgical error, you fix it, we're not paying for it. I'm not sure I want to go back under the knife knowing the doctor's doing this begrudgingly because he made the mistake the first time and he's not getting paid to fix it. And the hospital's not getting paid for me to be there. I'm not sure I want to do that, but that's the case. Also, with congestive heart failure, if you readmit the patient within 30 days of the discharge, Medicare will not pay for it. So they're beginning to say, you know what, we're going to force some kind of quality on you people. We're going to make you be accountable for something. But what's happening is the marketplace itself says we have to do something. Insurance companies, we're not going to just keep shucking out money and just throwing money at doctors for no reason. So we're going to change, and we're going to pay you for what's called fee for value. How do you do that? Pay for performance, P for P, is a fairly new concept. This has all happened just in the last few years. And what they do is, both in Britain and the United States, is that we're going to begin to quantify the human medical condition. We know what works. What should a diabetic, how should you treat a diabetic or other conditions? And they identified about 100 different health statuses, and it started in Britain. They said, we're actually going to pay our doctors more, and we're going to have them keep score sheets and send us reports on how they're doing. And we're going to actually pay them more if they keep their patients healthier. You know, what a novel idea. Well, the bottom line is it worked very well. The doctors made more money and the patients got healthier. What a great idea. So the U.S. starts with what's called PQRI initially, the Physician Quality Reporting System, fully voluntary. If you as a doctor will send us a report on, and they define some measures, you know, how many hemoglobin A1Cs did you do? Just some basic medical measures. Just send us the report and we will send you some money. It doesn't matter about the quality. You didn't have to say you did anything better. They just wanted doctors to get used to reporting to somebody. That's pretty huge, sorry about that, pretty huge change for a doctor to be accountable to outside organizations to report on the quality of the care that they're giving. So this was not easy. So it was voluntary. Here's some examples. I won't go into them, but for example, the percentage of patients age 18 through 75 with diabetes who had most recent hemoglobin A1C greater than 9%. All you had to do was say, yeah, I had 37 of those. They didn't judge you, but they wanted the doctor to get used to sending this kind of information to another agency, kind of setting them up for the future. And it worked. So beyond that, we're getting doctors used to sending off reports. But an even bigger change in the world right now is the way healthcare is being delivered. You may see the concept of a patient-centered medical home. And what that means is, you know, right now, what do you have? You've got all these siloed clinics. You've got your primary care doctor, you've got your dermatologist, you've got your cardiologist. They all have their own business. They really don't talk to each other, except maybe they fax letters back and forth a little bit, but they really don't collaborate at all. They're too busy. Your doctor fires you off to the cardiologist and he just hopes he gets a letter back after the visit and what happened. But they really don't call each other and talk very much. But with the patient-centered medical home, they agree that they will. And what they do is they say, your primary care doctor is going to be your care coordinator. And that doctor is going to start communicating with the hospital and with other specialists. Well, this is a pretty big change because he's not used to spending the time doing that, and he has been getting paid to do that. So where does your doctor, he or she, find the time to start doing all this collaboration and communication with other practices and clinics and the hospitals and nursing homes all over Jackson County? You know, it's difficult for them to find the time to do that. There's another thing that's come along. It's called the Accountable Care Organization, and this is really going to take over the country within the next 5 to 10 years. Medicare started it. They said, we're going to go a step further. We're going to not only have you guys collaborate, but we're going to turn it into a business. And we're going to pay you if you will jointly collaborate on behalf of your patients. And if you do a better job, if you improve their health, we're going to start giving you money for it. And when you finally put money into the picture, people start listening. So the ACOs are beginning to take off. Incidentally, it's interesting as you look at the politics. You know what the patient-centered medical home has been for 20 years in California? They call it managed care. And HMOs, Health Maintenance Organization. And I, prior to this, where I am now, I worked for one of those. Well, our CEO was actually invited back to the White House to collaborate on the stimulus package. But we don't want California managed care, and we're not going to call it an HMO. So they literally just, put more lipstick on the pig, called it an ACO, and this is the new business model. It's California managed care, pretty much. But the CMS said, okay, we're going to establish some programs. Call it shared savings. So we're going to take these doctors we're paying fee for service, and we're going to, if they can prove that they're saving us money, then we're going to share the savings with them. So they'll start making money when people aren't sick. They started that program. Well, how do we get there? How do you change a clinic from being paid fee for service to this other model without them going belly up? It's a tough transition. Well, then we're going to do some advance payments. We're going to front you some money to help you get started doing this. And then they had what they call, let's get some pioneers. Let's get some people to try this first. Now, who wants to step up and be an ACO? I'll show you in a minute what one of the biggest fears is of being an ACO. Well, they got some organizations to do this, to come together in a community and say, okay, we'll collaborate and we'll coordinate patient care across all of our organizations, and we'll call ourselves an ACO. And all of a sudden, outside of the government, which is 45% of all health care, the insurance company said, whoa, we're not going to be left behind. That's a great idea. Let's do that. Accountable care are often described as a group of doctors and hospitals that's responsible for every aspect of patient care. Cost and quality. Problem with managed care is all it was save costs. Well, I'm not going to have you run that test because I get to save costs. Well, it didn't matter whether maybe you needed the test. But there was no quality incentive. It was only cost savings. ACOs are both cost and quality. You have to show that the patients are healthier, and then you'll get more money. It's based on outcomes, whether the patient becomes and remains healthy, rather than the amount of doctor's visits. What a model idea. Here's the big kicker. These organizations become insurance companies, spreading the risk among its members. I mean, who assumes the risk for your health care right now? Blue Cross, Humana, whoever your insurance company is. They keep paying the doctor time and time again. Not going to be the case much longer. The insurance companies will not assume the risk. Your doctor will assume the risk for your health care. Huge change. Banner Health and Aetna and Phoenix putting up an ACO. So Cigna going to have 30 ACOs by the end of last year. They probably made it. United Healthcare going to have a new ACO in Tucson, Arizona. Humana down in Louisville going to have ACOs stood up. Going to have several ACOs stood up. Anthem Blue Cross putting up ACOs. What's the common theme here? It's insurance companies that are funding ACOs. Why? Well, here's a simple model. They identify patient population, and believe me, the insurance companies know more about your health status than your doctor does in many cases. They've got better information systems for years. Their financial systems can do more than a lot of our clinical systems do. So they know what it takes to keep diabetics healthy, CHF, obesity. They've known that for a long time. They know exactly. And so what they do is they're identifying patient populations. We're coming to Jackson County. I'm Humana. I've got 4,000 diabetics that are in my insurance plan. I'm going to go find somebody to care for these diabetics. We're going to baseline the cost. They know how much it cost last year to pay for the care for those 4,000 diabetics. They know it to the penny. The ACO is going to assume full risk for taking care of these diabetics, not the insurance company. We're going to come as an insurance company. I'm going to negotiate a contract with all you doctors, you ACO, and you guys are going to be responsible for keeping them healthy. We're not going to pay you for each x-ray, for office visits, none of that. We're going to pay a monthly maintenance fee per patient. So you're going to get X dollars per patient for our 4,000 diabetics. That's your income. At the end of next year, we're going to do an analysis. Did you save us any money? If so, we're going to share it with you. And this is where the big money comes in for the ACO, because the cost of health care is gargantuan, and it is not going to be hard to save millions of dollars per patient population if they start doing it right, in which case that's where they make their money. What's the new boundary condition? The healthier the patient population, the more money the ACO makes. A 180 on the business drivers behind health care. And that's really what this is all about. How can we incentivize the healthcare providers to do a better job, to take this seriously? By 2020, they're predicting there will be no health insurance, period. So what happens to Anthem Blue Cross and Humana and all these folks? They already are seeing what's going to happen. They're going to be brokers of a different kind. They're going to be agencies. They are not going to be assuming the risk anymore. So that's a huge business transformation. What in the world's going to happen to all the health insurance companies? You know, they're trying to figure out how in the heck do we survive as a business if we're going to transfer the risk of health care to the doctors. So there's a huge transformation going on in the business world right there. We're trying to increase the health and increase revenues, and believe me, yeah, specialists are making a lot of money, but your primary care doctor is not getting rich by any stretch. In fact, they can't get med students to come out and go into primary care. There's no money. I'm probably making as much as a primary care doc. They just don't make much money anymore. Any pre-med students? Well, you will definitely be faced with a decision at some point. You're going to go into specialty? You want to go into primary care. San Diego County cannot get a primary care student or a resident to come to San Diego County. For one thing, it's going to cost you $800,000 to buy your first house, and you're going to make $150,000 a year to start, maybe. It's like, yeah, I'm going to do that. Your beaches aren't that pretty, so it's not happening. It's a serious issue in Southern Cal. How do we attract primary all across the country? How do we even get a medical student to specialize in primary care? Tough call. How about a little help from our friends? I mean, don't you just love it when they say, I'm here to help you, I'm from the government? So there are new laws that have been enacted, and I'm sure you probably have heard it. It's called Obamacare. But in 2009, the American Recovery and Reinvestment Act was signed into law. $787 billion. Mostly for jobs creation. A whole lot of highways are getting rebuilt with stimulus money. And a whole lot of other stuff is being done with stimulus money. They bumped it up to $840 billion. They needed, I guess, more coffee funds. So it's up to, in 2011, they bumped it up to $840 billion. I want to talk about two of the many government agencies that were impacted with the Stimulus Act. One of them is the NTIA, National Telecommunications and Information Association. And then the Department of Health and Human Services. I mean, there's a lot more agencies that got money, but these two got quite a bit. So, just to talk briefly, why do we care about the NTIA? $4.7 billion to establish rural internet access, to increase broadband access out in Minot, North Dakota and Montana. Why? Why should that be important for health care? Well, in those rural communities, telemedicine could be an incredible lifesaver if they could transmit the radiology information over the web and get it back to the doctor in Denver, etc. So this is going to be huge for providing health care in rural settings, telemedicine. I didn't want to miss one other thing that the money went for, because it's really critical for what we're talking about. $650 million so they could send out coupons to everybody waiting to get off of their analog TV converter. $650 million so people could switch to digital TVs. And of course, it had to be mailed first class. So your tax dollars hard at work helping the folks. At least they can watch TV now. I mean, what's important? So, but HHS got a little money too. Health and Human Services got quite a bit of money, and you can see the second one there. Health Information Technology got $25.9 billion. Now, what in the world are you going to do with $25.9 billion in healthcare IT? They established a Medicare, Medicaid, EHR incentive program. EHR, Electronic Health Records. Incentive payments to eligible professionals, hospitals, and critical access hospitals who demonstrate meaningful use of a certified EHR. You can start in 2011, last year. It's running for about 5 years. They will give a doctor $44,000 if he'll put one of these in and use it. Well, money talks, other things walk. So when they throw $44,000 at a doctor, which is enough to pay for the whole system, all of a sudden it's like, well, maybe I'll take a look at this now. To get the maximum incentive, it's a declining scale. If you put it in by October 1 of this year, 2012, you'll get the full $44,000. If you wait after that, 2013, 2014, 2015, it goes down kind of quickly. Now, hospitals get some serious change. It starts at $2 million per hospital and then goes up from there. CHS down in Nashville, they said when we are done implementing in all of our hospitals, our check from the government will be over $800 million. Worth doing. You know, that'll pay for a couple consultants to come in and help out. So they're all over this. Hospitals are all over it. However, in 2015 and later, if you have not successfully demonstrated meaningful use, you'll have what the government calls a payment adjustment, which means we're going to stick it to you. If you don't take our carrot, we will beat you with a stick, and you will get less money for your Medicare. So by 2015, if you have not put this system in and used it meaningfully, you're going to lose money. Kind of a done deal. Everybody in the country is after companies like mine. When can you get me up on meaningful use? How about tomorrow? So right now, every doctor in the country is trying to figure out how in the world can I get up on meaningful use quickly. Meaningful use, of course. Interesting term. You can't just buy it and have your front office use it to send out bills. Of course, they've got page after page of you have to show to, remember I told you they were getting the doctors used to sending reports in? Well, you ain't seen reporting till you see reports now. Meaningful use, for example. I mean, I won't go through all of this, but all the ways that you have to attest that we're using it in a meaningful way. We're providing the patient with a complete summary of their health status when they leave. We're monitoring this. There's page after page after page that you have to show we're doing all these things to prove that you're using it a meaningful way. What the heck's a certified system? That's only a 66-page document describing what a software package has to have in it to be certified. So, you know, government's doing a good job making sure everybody, you know, reports a lot. Bottom line is there's probably about 100 certified systems out there that you can use. For all of this to work, what has to go? Oh. This junk. I mean, healthcare still lives and dies on the paper medical record. Well, how in the world are you going to, you remember I talked about the PQRS? Hardly anybody does it because they have to have their staff troll through paper charts to gather the data. It's not worth it. There's not enough money they're getting, so very few people did it. They only do it if they've got a computer system where they can just crank out the report. Paper charts have to go, and this is huge for the doctor because he has been living. One of the medical directors at a group out in Northern Cal, he said, I just call it the doctor's binky. You know, they won't let go of it. They got to have that paper chart. We put in an EHR system for Catholic Healthcare West up there, and guess what some of the doctors did? Had their nurses print it all out and hand it to me so I could take it into the patient. So, well, there's a real good use of electronic information. Every visit, print it all out. so I can take it in and I'll write on it, and then you put it back in. Come on, guys. So there's a bit of a battle over using these systems. But there's new information systems out there. I don't know if you remember me being here years ago. I actually started a company that wrote an EHR system. This is back in the early 90s. If Obama had done this 10 years earlier, I'd be a rich man. But I don't care. It's just fine. My system never would have got certified, probably. But doctors didn't want to buy it. Now they will. For one thing, technology is a lot better. You know, it's come a long way. But to actually put a system in that a physician will use in the exam room, sitting with you as a patient, discussing things with you, and entering lab orders, and putting in instructions, and, you know, I had one guy said, this isn't just business process re-engineering, it's a religion change. I mean, talking with doctors, this is huge. I mean, you got a guy, a thoracic surgeon who's in his early 50s who is at the top of his game. And he gets me behind closed doors, and guess what? He's scared to death he's going to look like an idiot in front of his patients. I don't know how to use this thing. You know, how am I going to use this thing? And this is a guy who published around the world, world-renowned, scared to death of this crazy computer because he's going to look like a fool. This is some tough selling, working with doctors. But to me, it's the most rewarding because when it succeeds, it's incredible. We've also got acute care, inpatient systems, all kinds of different systems on the hospital side. When I hired on with Allscripts, where I am now, I've got probably 20 years working in outpatient systems. I said, if you'll hire me, do you want guys that want to learn your hospital systems? Oh man, yeah, we don't have anybody who knows both of them. You know, they've got these two huge silos. You're either the hospital guy or you're the ambulatory guy. So, good grief, I flew to Atlanta every week for I don't know how long, going through all their hospital training. That was pretty informative. I'm probably the only guy out of 6,000 in the company that knows both systems. And I remember you saying one time, Dr. Carey, if there's one thing that you want to do is don't be afraid to learn something new. And the fact that I even volunteered to do it was like, wow, really? You want to do that? Now guess what? I'm getting called for, can you come help? I'm getting all the ugly ones now. Hey, you're the only guy that can fix this mess. So maybe sometimes you don't want to volunteer too much. Post-acute care, home care, nursing facilities, they all need these systems. And another huge factor called Healthcare Information Exchanges, HIEs. I actually was appointed to the California State HIE Technical Working Group in '09. Well, a group of about 28 of us defined the technical standards for California's HIEs. What a trip, that was very enlightening. What's an HIE? That's so that my EHR system can send your entire medical record to your competitor's EHR system, or to the hospital, or to another practice. So how does the community communicate? Because with these ACOs, they're not going to all just dump all their systems and everybody buy a new one. They're going to keep all their systems, and there may be 15 different vendors involved. You have to have an HIE so you can transfer the data among all these different organizations seamlessly. But to me, the most exciting thing is what's called analytics. When I worked at Microsoft for a while on the SQL Server team, I was on their data warehousing team when they first started data warehousing, OLAP, Online Analytical Processing. And the only people they were working with were financials, banks, insurance companies. I said, why don't you guys, have you ever thought about healthcare? Healthcare? You got to be kidding. So when I left there and went into healthcare, the business unit manager announced to the whole team, Evoy's going out to build healthcare data warehouses. And there was a big laugh, and off I went. And do you know what MS Hug is? The Microsoft Healthcare Users Group. What's the first vertical market Microsoft went into about 3 years after I left? Healthcare. You know what Amalga is? It's their healthcare data warehouse. I went back to Building 6 when I was up there a while back, and I just kind of stuck my head in the door and I said, pretty dumb idea, wasn't it? Oh, shut up. Here's the real winner in what this is all about. Evidence-based medicine decision support. How can we help the doctor at the point of care? How is the doctor going to do a better job with your health care? Well, there's a ton of research out there that here's what you ought to do with diabetics or CHF. But does your doctor know all that at the point of care when he's talking to you? Probably not. But these systems when the doctor brings up your chart electronically, it says, whoa, we got a diabetic here. And they haven't had a foot exam in 3 years. Supposed to have it every year. They haven't had a retinal exam in 5 years. Supposed to have it every year. They haven't had a hemoglobin A1C for 6 months. Hey, doc, here's what you ought to order. Boom! He clicks a button. He's just filled in gaps in care. And this alone is going to turn the whole healthcare industry around in terms of filling in all the holes and gaps and things where they're missing what they're supposed to be doing for you in health maintenance. Population-based tracking. Run a report every week. How many of my diabetics need some kind of help? And it'll tell you, here's what you got. You got 88 people that ought to have these following things done. I mean, what a way to begin to improve the quality of healthcare. Got to hustle here. Data mining. Man, there's some cool stuff going to go on in data mining. When you get terabytes and petabytes worth of data in here, some of these data mining algorithms, they don't even care what's in there. You just sick the algorithm on and it'll tell you what's in there. Here are the patterns, here are the relationships. Who knows what we're going to find when we can start doing serious data mining on these things. So these are obviously pretty simple systems. It's, you know, you put the CD in the drive, you double-click setup, and in 30 minutes you're running. Almost. That might get you the e-learning. What does it take to implement one of these? Outpatient, 5 to 25 people on the team. Maybe you can do it in 90 days if you really haul and nothing goes wrong. But it's probably going to take you a year, year and a half. Anywhere from 500 to 3,000 or more man hours, all billable. That's why my company made $1.4 billion last year. It's all billable at some pretty decent rates. That's just for an outpatient system. Fairly simple. Hospital systems, you can. They're doing a go-live down in Indianapolis right now. I couldn't get in my own hotel because they're doing a go-live at a 600-bed hospital. There's over 100 people on site as the support team. Just, you know, running around the hospital, making sure everybody gets their question. For 5 weeks, there's 106 people being billed at probably $150 an hour plus to support this hospital go-live. And the system itself costs probably, you know, $20 million. So, I mean, Kaiser Permanente, when they implemented their EHR across their 12 regions, ended up spending over $3.2 billion to put it in. They hired thousands of people, and it was unbelievable the effort they put in to getting that in. Right now, probably 1/3 of the doctors have an EHR. So we are less than halfway. They say 57%, but most of them aren't using it very much. I mean, you call a doctor, do you have an EHR? Yep, we're using it. You know, maybe they're doing e-prescribing. So anyways, I'll hustle here. Who are the employers in all of this? I wanted to get to the jobs part. I think that might be a little interest to you. The vendors, companies like Allscripts, who I work for, acute ambulatory system developers, diagnostic service providers. The clients, I worked on the customer side too. I worked for Sharp Healthcare in San Diego. I was a customer of Allscripts. That's why they were glad to hire me. Was, wow, you know our system already. Physician groups, hospitals, radiology center. Anybody who provides healthcare service is going to need some kind of help with information systems. There are consulting groups all over the place. I worked for Perot Systems for a while. I was a project manager for Ross Perot's company. They will do complete turnkey solutions and come in and do the whole thing. Accenture, EDS, these are big international consulting firms. There's a mess of smaller consulting companies that you can work for they will farm you out and send you where you're supposed to go. And I know a lot of people that work as consultants in this arena. What are the jobs? If you like working with people, sales and marketing, project management, implementation consultants, they call them, clinical consultants, education and training, help desk. And I want to make sure you understand this is not for geeks only. In fact, I don't know very many people in this category of job that really have an IT education or background. I've got a lot of nurses on my teams, a lot of medical assistants, physicians, office managers, people who understand clinical workflows. You really don't have to be an IT major or a math major to get involved in the healthcare system. They really need people who can understand what goes on in a medical practice. If you don't like people, there's lots of things you can do, you know, back behind closed doors. Or if people find out that you shouldn't be working with people, which it happens. Yeah, I spend half my time swapping out staff. Oh, you really don't belong here, do you? We have a large contingent in India. Does a lot of our basic programming, so it helps if you can if you speak a little Hindu. It is tough communicating, it really is, and that's a battle all the time. But servers, networks, our tech ops guys are incredible. You know, we actually build out the servers, whether the client has them. We have our own outsourcing group, our own data center, so we do a lot of that. But I just talk real briefly. What would a sales guy do? Anybody here interested in sales or marketing? If not, I won't waste my time too much. Okay, not too much. So this will be a real quick slide. But this is not just taking an order. These contracts, you know, can be 40 pages long, and you have to describe everything you're doing, interfaces, what modules, what specialties, what locations. I mean, it can take anywhere from 3 to 18 months to close a deal. So you got to have a little patience, because sales guys are used to, you know, churn and burn because they're getting commissions. They want to turn it fast. Got to have some patience in this environment, because especially if you're selling to a hospital, it may be 3 years before you get the deal, and then you hope you didn't lose it, you know, to McKesson. So high risk, high money. Project managers, I did this for quite a while, and basically, if you want to go to PMI.org, the Project Management Institute has a website, and project management is a real discipline. It might sound kind of funny, but there's a book called the PMBOK, Project Management Body of Knowledge, that you study, and you can actually become a certified professional PMP, professional project management professional. You know, because I used to be a certified pimp. I'm not anymore, but. It expires every 3 years because people get a little embarrassed putting that on their business card. But not only do you manage the project, you have to acquire the resources. So, you know, I'm just going to wrap up by showing you what in the world does a project manager do. You know, I don't know. It's a little late. I won't. It's pretty extensive. You have to put together the teams. Like, for example, the project I'm on in Indiana, or at Sharp, I had to hire like 18 people. Okay, I'm looking for implementation consultants. I'm looking for database guy. And so when I get into, when a contract gets signed, I get the contract, and they say, okay, go find the people. We have a scheduling department, and okay, I say, hey guys, I need 2 practice project managers and 4 ICs and 8 trainers, and I have to go interview them and do all the training. So there's a lot to that. But then you make sure it all happens. Project management. But I will say that most executive positions are being filled by people coming up through project management as opposed to finance nowadays. They want people who understand how to execute things. So implementation consultants are the people that learn the system and come in and help go out and talk to the nurses, work with the practices, talk to the doctors, and build the system. So, and of course, if you've got 5 years experience, you can get a job right away. Problem is, we can't find anybody with 5 years experience. So Allscripts has actually done a pretty good program of, they started in Vermont this last year, and they got 30 students right out of college, and they went ahead and trained them and put them through a program. Part of the money funded from the stimulus money. But what we ended up with is 30 people who are now qualified interface developers in some of our, so it's a great start. I mean, you do that for a while, you understand the systems. I was an interface guy for a while, and you know, so they will move through that, they'll move into other things, but they're in the door. 30 students right out of college working in, you know, a pretty senior environment, and it's, you know, it's a great program. Actually, who we are, we've got over 200,000 doctors using our systems in 1,500 hospitals, about 10,000 post-acute care organizations, a little over 6,000 employees, and we're headquartered in Chicago. And it's so cool that we even got on Mad. How can you beat that? I mean, he says that we're undervalued. So if you're looking for a hot long-term investment, go buy Allscripts stock. I want to go ahead and cut it off right here. Any questions or anything? Yeah.
You had stated right at the beginning of the day, you know, as far as are we the safest healthcare in the country, and you had a lot of stats as far as things that happen within the United States with medical errors and those sorts of things, but you really didn't speak to other world situations such as France or England as far as their stats go as well. So.
I don't have stats, but you know it's happening there too.
Exactly.
Yeah, we just don't have statistics for how many medical errors are happening in other countries. For some reason, they don't tend to share that a lot. But yeah, you know it's happening everywhere. It's just, it's happening here, and there's something that we should be doing about it, and there's something we can do about it. Anything else? Yeah.
I've never heard of the ACO before, and I really like the idea of it. And you think it's going to be implemented? You said in 5 to 10 years.
What's that?
You said the ACO would start like being functional and implemented in 5 to 10 years.
Actually, they're already being implemented, and they'll probably take over the world in the next 10 years.
Do you think, this might be totally off topic, but in any way, do you think the presidency might have anything to do with that? Because I know Obama has like all his Obamacare plans and whatever. Do you think if we come under a new president?
Good question. The question is, do you think the presidency has anything to do with all this? Absolutely. The Republicans come in, they're going to repeal it. What's the biggest complaint about the stimulus law right now? You're forcing me to buy health insurance. It's my choice. But no, it's not your choice. The law says you must buy health care insurance. We're going to make you buy it. They're not even sure that's constitutional. Republicans are saying we get in the door, and that whole Obamacare thing is out the door. Now, most of the money involved in healthcare IT has already been allocated and is being spent. So we're too far down the road on the IT systems. But the law itself, good point. If the Republicans win, there's a real good chance that this thing's going to get at least hacked to pieces, if not totally repealed. This stuff's always political. Yeah?
You talked about like accountability with physicians, but what happens if like a patient doesn't do what is recommended and they don't get better? Is that what's looked at as the physician's fault, or is it taken into consideration?
Oh. Good question. Question is, what happens if a patient doesn't do what the doctor says? And one of my cardiologists had his cartoon up there. It literally said, so go ahead and tell me what it is I'm not going to do. The reporting system has a code for that, patient compliance. And so you can literally say, this patient, I told them to come in for their lab tests, they did not do it. And it goes on the report as patient non-compliance, and it does not go against the doctor. What it does do is help the doctor know whether they are being compliant or not. Because with electronic prescribing, if you prescribe 3 meds, the system will actually tell you when they picked it up at the pharmacy. Now, what's really cool is if you're ever in Redmond and Microsoft and go to their home of the future, these little tiny RFI chips that are getting smaller and smaller, they are eventually going to be in everything you consume. So literally, they'll even be in the pill you take, so they will actually be able to tell when you take your pill. That's pretty scary. But they will, I mean, they're getting to the point to where, how can we keep track of patient compliance? It's a huge issue. Patients don't do what they're supposed to do. Yeah?
Thinking about the malpractice insurance, if you have these checklists that are going to be implemented with everything the doctors are going to be doing, would that possibly lower what malpractice insurance would be for doctors and possibly save them money down the line, seeing as they can follow instructions that have been written down as to what you do in this situation?
Yeah. The question is, would these systems lower malpractice insurance? In fact, state of Michigan was one of the first ones to do that back in the mid-90s. If you have an EMR, we'll knock 5% off your malpractice insurance premiums. And more insurance companies are doing that. And absolutely, I mean, as a doctor can show statistically, here's how I'm doing a better job, here's how it was not my fault, it's bound to continue to decrease malpractice insurance. Yep. Yeah. Talk up, I'm half deaf.
My question, I guess, is if you have these databases and stuff that you're storing electronically, something goes wrong, now I've lost my information. I guess is kind of my question, as a future doctor.
What can go wrong? What could possibly go wrong?
If it's a Mac, it's good.
Oh, if it's a Mac, you're home free, right? No.
Amen.
No, I mean, if I'd had the time to show you the project plan, there's a whole section in there on disaster recovery. What do we do? You have to lay, okay, doctor, in the event of, I mean, a lot of these systems are delivered over the internet and in the cloud, so we don't even have our server here. What if my ISP goes down? Now what? So there are backup, literally we actually say, okay, if it's going to be more than 2 hours, here's what you do. If it's going to be, we literally have paper forms, ouch, standing by. If you have to, go back to paper. We actually, one of my guys, he and I, we developed a system that would mimic, you could actually do simple data entry on a local server to keep going, and then once connection was reestablished, it would load all that data back to the database. So you can keep going, but you have to have those plans. And not to mention that that data center had better be completely replicated someplace else away from the fault zone. Yeah. I live in California. This is all you think about is faults. I don't deal with tornadoes, just faults. Any other questions? Yeah.
Does Allscripts employ scribes? I know that seems to be a new job market.
Employ who?
Does Allscripts employ scribes?
Oh, yeah. Good question. Huge deal. One way to get a doctor to involve in this, you know, I mean, medical transcription is going to kind of go away, but not the concept of a scribe. And actually, what you do with a scribe, and there are consulting firms that's all they do is provide scribe service. Let's say you're a dermatologist. Dermatologists see 60 patients a day. I mean, they're flying through their patients, and they need to do a lot of documentation. I was at my derm one time, had 3 scribes in the exam room. There was no room for me. I'm in this, you know, this little Kleenex with 3 girls and him. Well, this is really kind of strange, but they were scribes. He would dictate, and this one would do this, and dictate, and they were doing all the data entry, and so he did not have to. Scribe, I'm not sure how long that will go. Probably for a couple of decades, where scribes will be a really good add-on for certain kinds of specialties. You have to cost justify it, because now you got the cost of a scribe. But if you can see more patients, or if they can build it into the ACO finance model, which they probably will, then, because what it really comes down to is, at the end of the day, if the doctor doesn't use it, nothing else matters. That's kind of one of Allscripts' little acronyms. And we can throw money at them, and we can talk about quality and all that, but if you can't get a doctor to use this, it just, and we've got a lot of them I know that are retiring. Forget this, man, I'm out of here. You know, a pediatric surgeon next to LA Children's Hospital, I'm done. Wow, man, there's a wall full of plaques and certificates, I'm done. So how do we get doctors to use these systems? Scribes is an answer. Voice recognition Dragon version 10 is incredible, and that really has come a long way. You can just talk and it'll just fill out the whole form for you. So we're getting there. Tablets, iPhones, iPads, you know, remote is the wave of the future. Docs just want to do it on their iPad. I got a doctor that does half her charting riding the ferry across to Coronado Island in the morning. And it's, so there's, but it really comes down to working with the doctors. They're really stressed out. I got to tell you, I think one of the most rewarding parts of this business has been getting to know doctors personally, you know, behind closed doors. I had the head of Kaiser's oncology department in Riverside was an Egyptian oncologist, Dr. Fawaz Gilani, got his MD at Oxford, probably the most widely published oncologist in the world. Shut the door and said, let's talk. Says, you realize I don't win any? Says, by the time they get to me, oh, I don't either. By the time they get to me, the best I can do is minimize their pain until they die. And I go, wow, what a life. And his phone rang, and I offered to get up and leave. No, sit. He talks, he says, yes, you know, your mother has stage 4 cancer. She probably won't last 90 days. We'll do our best to make her comfortable. Hung up, he goes, well, another satisfied customer. You got to have a strange lifestyle to be some of these doctors. I would not want to be one. Yes, ma'am.
When I go to my doctor, the nurse or nurse assistant will take down what my information is. And then when the doctor comes in the room, he repeats that and takes it down on his computer. So it's been entered twice. And I can't help but wonder, why do they need to do it? Why shouldn't the doctor just come in and pull up what I just said?
Yeah. Well, in ours it does. You must have a really lousy system. It must be a cheap EMR. No, but that you're supposed to do electronic handoffs. I mean, yeah, shared noting. Well, yeah, that's exactly what you want to get away from is duplicate data entry. Yep. Anything else?
Well, these have been excellent questions. I know that I am going for lunch with Jeff at about 12:30. If we're sitting at the cafeteria and you want to join us,
yeah,
please
come on
do
in.
so. And if you have questions, I'm sure he would give you a contact information to keep in touch. There are jobs for strong liberal arts thinkers that can cross disciplines. So whether it's biology or finance or computer science, Health IT has a job for you. So
We hired over 1,000 people this last year. We're looking for another 1,000 this year. So there are a lot of jobs out there.
give him a hand.
Thanks. Happy spring break.